The United States Department of Health and Human Services in 2006 reported that as many as 250,000 children and adolescents were in the custody of the United States foster care system. The youth in foster care tend to be disproportionately from low-income families and neighborhoods, are generally comprised of higher percentages of ethnic minorities. Studies have also found that children who have been or are in foster care have higher rates of mental illness than the general population. This disparity is seen, in part, due to the complex trauma that foster care recipients experience before being placed in care. Complex trauma describes interpersonal trauma, such as the loss of a loved one and the grief associated, maltreatment, and impairments in attachment, association, cognition, and other areas that are indicative of several mental disorders. According to the National Archive on Child Abuse and Neglect in 2010, 53% of the children in foster care have been neglected, 28.2% have experienced parental substance abuse, 15.3% have experienced physical abuse, and 4.4% have been sexually abused. In 2015, Jackson Foster and others found foster care alumni to be resilient and observed post-traumatic growth and mental development. This growth was hampered with punitive or abusive foster families and amplified when paired with nurturing, supporting, and loving foster families. In short, repeated abuse, or reoffense, contributed to a lasting disturbance in the mental well-being of foster care alumni. These lasting disturbances can be seen in mental health and high-risk behaviors, such as drug abuse and sex. In the same study conducted by Jackson Foster, they found evidence to support the claim that foster care alumni that were traumatized while in care had higher rates of comorbidity. The study examined rates of major depressive episodes, panic attacks, alcohol dependence, drug abuse, panic disorders, social phobias, generalized anxiety disorder, post-traumatic stress disorder, anorexia, and bulimia. The study found that girls tend to have more internalizing disorders, such as panic disorders, depression, and PTSD. In general, girls have over 2 times more mental disorders than their male counterparts. This may be due in part to the fact that women are more likely than men to be emotionally and/or sexually abused. Another study by Jones in 2014 tracked the rates of substance abuse, such as drugs and alcohol. Immediately following discharge or disenrollment, alcohol and drug abuse accounted for 17.8 and 27.5% of the study population, respectively. 3 years post-foster care, the percentage of the population involved in alcohol abuse had risen to 37.5%, and drug abuse had risen to 31.3%. Alcohol and drug abuse were also linked to other high-risk behaviors, such as unprotected vaginal sex. A study examining the relationship between substance abuse, mental health, and HIV risk behaviors found substance abuse to be the greatest predictive factor to HIV risk behaviors. These HIV risk behaviors included vaginal sex without a condom, anal sex without a condom, oral sex to either gender without a barrier, and sex while on alcohol or drugs. Adolescents who use alcohol were 4 times more likely to have unprotected vaginal sex and 2 times more likely to engage in any HIV risk behaviors. Participants who use marijuana were 5 times more likely to have unprotected vaginal sex and 2.5 times more likely to engage in any high-risk behaviors. Behaviors related to poor impulse control, such as delinquency and ADHD, were also predictors of HIV risk behaviors. Impulsive participants were 3 times more likely to engage in any high-risk behaviors and greater than 4.5 times more likely to have unprotected sex. This evidence is congruent with findings by Jones, which indicated that treatment for sexually transmitted diseases among foster care alumni rose, on average, by 2.73% per year. Just as unprotected vaginal intercourse is a predictive behavior of HIV risk, another study denoted unprotected vaginal sex as an indicator of pregnancy risk. Kerr and others examined the effects of multidimensional treatment foster care, hereafter MTFC, on the pregnancy rates of children currently enrolled in the foster care system of Oregon. All participants had to be deemed at high risk of pregnancy, which was evaluated by looking at factors such as the delinquency, sexual activity, and alcohol or drug use of each participant. Girls not enrolled in MTFC were twice as likely to become pregnant between the ages of 15 and 18, with 46.9% becoming pregnant. Girls enrolled in MTFC were still more likely than non-foster care children to become pregnant, with pregnancy rates of 26.9% as opposed to 2.23% of the general population. Just as trauma has lasting negative results for children, protective factors, such as a nurturing foster family, can have lasting protective effects. Many agencies in the U.S. have begun the shift from traditional placement to kinship placement of children entering foster care. For a placement to qualify as kinship placement, the guardian must be related to or have known the child being placed in their care prior to the enrollment of that child in foster care services. Children placed in kinship care tend to receive fewer social and mental health services, as well as a noted tendency for kinship placements to be located in low-income neighborhoods and for their guardians to earn wages under the federal poverty line. However, children placed in kinship care had fewer reentries into the foster care system, lower rates of maltreatment while in care, and less placement instability. Perceived agency helpfulness also seemed to play a role in the mental health of foster care alumni. Participants who reported higher perceived agency helpfulness were less likely to be diagnosed with mental illnesses. One aspect of perceived agency helpfulness measured was the readiness felt by foster care alumni when aging out of care. The study by Jones in 2014 found that regardless of perceived agency helpfulness, 43.7% of foster care alumni were without health services such as insurance 3 years after care. This number was a large increase from the percentage of foster care alumni that did not have access to services immediately following discharge or disenrollment, which was 1.1%. One protective factor that was not anticipated was that of contact with the birth family, especially contact with grandparents or siblings. Boyle in 2015 found that children in adoption or long-term foster care will lose contact with their biological families, generally as a result of a TPR. A TPR decision is made by a judge and usually results from extreme abuse or neglect. However, Boyle found that positive contact with biological family members can help foster care children to form new attachments, resolve the grief and loss associated with parental abandonment or alienation, and help children to form a new dual identity. Though protective factors can aid children in resiliency, significant focus needs to be had and drawn to the adverse effects experienced by children in foster care. Foster care alumni have lower access to physical and mental health services, tend to earn lower incomes across their lifetime, and experience greater risk of pregnancy in teenage years. In short, actions that have been shown to be protective factors, such as access to services after discharge or disenrollment, perceived agency helpfulness, contact with the birth family where appropriate, and kinship care need to be increased and should be the primary focus of foster care agencies today.